Hello, everyone. Welcome to the session on research and policies on the horizon. My name is Richard Knight, and I will serve as moderator for this exciting session. During this session, we will discuss 4 or 5 topics that are very current and relevant to the kidney patient community. The first topic we're going to discuss is the use of eGFR. Is it a relevant measure? To discuss this topic, we have Dr. Gadegbeku, who is a founding member of the Diversity and Inclusion Committee and a member of the Public Policy Board for the American Society of Nephrology. She is also a member of the National Kidney Foundation, American Society of Nephrology Task Force on reassessing the inclusion of race in diagnosing kidney disease. This is a very talked about topic, and I couldn't think of a better person to provide some insights and balance to the subject. Dr. Gadegbeku, the mic is yours.
Thank you, Richard. It's such a pleasure to be here again for your Policy Summit, and I'm excited that this is the 4th annual Policy Summit that you're having. Today, I'm happy to talk about much active discussion that's been going on with race and estimated kidney function or estimated GFR. So obviously, assessment of glomerular filtration rate or kidney function is really important in medicine. It's important for several reasons. First, the clinical practice. It's important for detection and management of chronic kidney disease, but it goes beyond this. It's important for everyone in that it's important for knowing how guiding drug dosing and evaluation of people who develop kidney injury, acute kidney failure, and recovery. So it definitely goes beyond patients who suffer from kidney disease. It's also important for advancing our research. We need therapeutic advancements for kidney disease, but beyond this, we also need to be able to develop drugs that are safe. For instance, you'd like to have a cancer drug that has no injury to the kidney as a better cancer drug than one that does. So it's important for research, and as well, it's important from a public health standpoint to understand how kidney disease is changing over time, the number of people, for us to guide health policies that best protect humans. So we have to start from the beginning, and understanding the properties that make an ideal marker for kidney function are really germane to this issue. So the kidney, as depicted here, and as one knows, has a number of glomeruli, a million of these filtering units that filter the blood every second of every day. And in order to be able to measure that function, we need to have something that is produced at a constant rate, that is not protein bound, not metabolized or broken down, freely filtered, not secreted, and not absorbed. That would make the perfect marker of kidney function. So unfortunately, we don't have that perfect marker of kidney function that is available to us on an everyday. Measurement of kidney function, true GFR, is quite complicated. What we do is we use exogenous substances, or substances are not made, that we can put in the body and then measure them over time. The gold standard measurement is called inulin, which is not often used anymore. Mostly we use these radioactive tracers that allow us to measure the amount of radioactivity that is eliminated over time. And they're linked to iothalamate, EDTA, or DTPA. Those are just some substances that we link these isotopes to. And the way it's measured is it requires multiple timed measurements and measuring blood and urine over hours. So as you can imagine, this is not really clinically feasible, but is often used for research purposes when we really need to know the exact measured GFR, and it's been used to calculate these estimating equations for GFR. So what we do use is not an ideal marker, and it's serum creatinine that many of you know about. It is an endogenous marker, meaning that it is made by the body, so that we don't have to add something to get this GFR measurement. But it is not ideal in that it is not constantly produced. It is actually differs over age, if there's a loss of limb, and based on diet. It does satisfy the several properties of not being protein bound or broken down, and is freely filtered, but is also secreted, so to a range of 10 to 15%, and it's variable in different people and variable from day to day. It is also not absorbed. However, it is very easy to measure and can be widely measured, and as pointed out here with the STAT sensor, it can be even measured at the point of care. However, the problem with serum creatinine, because it is not perfect biomarker, one of the main issues is that it is not very sensitive, particularly at high measurements of GFR. Here I have two graphs that show inulin clearance over the range of 0 to 120 and the serum creatinine measurement. And as you can see, from 120 to 60, there's very little change in serum creatinine. And so when you're thinking about a marker that's going to help you to detect kidney disease early and changes in kidney function, it is not very good. Therefore, equations were generated to take the serum creatinine, which is an easily measured marker, and extrapolate to kidney function measure, or GFR. And I just like, in order to really understand the issues at hand, I'd like to take you through the timeline of development of these equations that has led us to where we are today. So in 1976, the Cockcroft-Gault equation was the first estimating equation of GFR. And it's very notable that it was built with 249 white men. And that became the standard measurement of kidney function. Did not have women. The measurement for women was something that was calculated and obviously did not have any other race included. In 1999, nearly 20 years later, we had an improvement of this measure to the Ndrd equation, which was generated from a study of kidney disease, had now included white women and 12% Blacks in the population, a much larger population, but was designed for kidney disease. There was some concern that with a very homogeneous population, that it may not be as useful in the Black population. And therefore, when the African American study of kidney disease was performed, they decided to again measure GFR using these research methods, and actually validated the Ndrd equation as being accurate in self-reported Black individuals. However, these equations were limited to patients with CKD. And so in 2009, there was an advancement to actually be able to use an equation that measures throughout the length of kidney function, and also to increase the number of patients, diversity in the population. And that's when CKD Epi came about. Both of these Ndrd and CKD Epi equations had a race modifying characteristic. Then CKD Epi was actually created with cystatin C, which did not have the race modifier involved, and created a lot of initial excitement. However, being that this was an expensive measure, really did not catch fire. And here we are today, 2017 to 2020, in which the issue of having race in a calculation was questioned. So going through each of these equations, Cockcroft-Gault, as I said, was used to measure creatinine clearance. Therefore, it is inherently an overestimation of actual GFR because the creatinine is secreted. Again, it was developed in a small white male population, and therefore the extrapolation to females was simply a calculation that had not been proven. Unfortunately, because it was done at the time of many medications were approved, it still has become, for most part, the standard for medication dosing. The Ndrd equation, quite an advancement developed in CKD, had been tested in several CKD populations, was a much, much more complex equation and had the race modifier characteristic in there because of the population that it derived this in was found to have, when compared to GFR, and we'll talk about this more, the need for that for accuracy. The one thing about both MDRD and Cockcroft-Gault, but mainly focusing on the MDRD equation, because it was derived in patients that had CKD, it was not really feasible or accurate in patients beyond a GFR of 60 mils per minute. As you can see, each of these represent an individual patient who had both a measured GFR on this axis and the estimating equation. And therefore, it is really based on to be used in patients with kidney disease below 60 mils per minute. The CKD epi equation was an advancement of this in that it took GFR measurements from multiple studies in its development, 10 studies across the range of GFR, so that could be used in every type of patient, not just CKD, and also validated in 16 more studies using many, many more patients, a much more complicated equation than the MDRD equation, but had the advantage of being able to be used across the span of GFR. So then came cystatin C, a newer marker, and the benefits of this marker is that it was not dependent upon muscle mass or a diet, and is not secreted. So in that sense, it was a better marker. It's derived from nucleated cells. It does have some things that influence it, like steroids and thyroid function. But the real limitation here was that it was expensive, and all centers and institutions weren't able to have it, and so therefore not very feasible. And that's why we haven't had serum creatinine still based equations became pretty much standard. So what about race in any measure for clinical medicine, but specifically with the measure of CKD? So first of all, race is not a biological attribute. It is a man-made social construct. And there lies a lot of problems, namely race in precise proxy for ancestry, which is genetics. And often race is assumed in the clinical setting, making it even more inaccurate and less able to be less viable as linked to biological attributes. In many of these reports, and all of them that have measured GFR, except there's some question in MDRD, these were based on self-report, which is not always the case in the clinical setting. A major limitation of this is we do not live in a black-white world, right? We have multiple races, and we have multiracial individuals, and therefore these equations don't include or account for that complexity of the diversity within our society. And another major issue is we all know that CKD, that there's significant health disparities within CKD. And so it's very important that we get this right in a population that may have increased susceptibility towards kidney problems. So going back to this graph of serum creatinine on one axis and GFR measured by the research method inulin clearance, it was noted very early on that there was, at a given GFR in a measured way, that there was a significant difference between the actual blood level of serum creatinine in someone who was white or black in early studies. This was also supported by National Health and Nutrition Examination Surveys and Haynes, which is reflective of general population, in which the serum creatinine in the general population was slightly higher among Black and white men and women in this population, but did not account for measured GFR. Very interesting study came more recently looking at genetics or African ancestry in serum creatinine. This is a quite fascinating study that includes African Americans and Hispanics, of which there is a wide range of African ancestry among these populations due to admixture of genetics. And in looking at that population, it was noted that for every 10% increase in genetically proven African ancestry, the serum creatinine rose by 0.02 units, suggesting there was a relationship with genetics and African ancestry and serum creatinine that may account for these differences in the serum creatinine in these population studies. Further in support of this study done in Europe, which looked at two populations that were essentially very, very similar from the standpoint of measured GFR, 302 Afro-Europeans and white Europeans. Measured GFRs were identical. Their age was very, very similar. The proportion of men and women were similar. Body surface area or their size was similar. However, serum creatinine was different, higher in Afro-Europeans. And also the excretion of creatinine, the filtration of creatinine was thereby different. And to some extent that there was a trend towards an increase in creatinine secretion in the Afro-Europeans. And this may be accounting for this different and actual blood number of serum creatinine, however, not a difference in actual GFR. So it goes back to the fact that creatinine is not a perfect or ideal measure of GFR, and there may be some genetic and environmental or a combination of genetics and environmental issues associated with the difference in the serum creatinine that are not related to the GFR. In the full age spectrum or fast GFR commonly used in Europe, which has not been explored in the US, they have been able to relate serum creatinine with age, and based on sex across the age spectrum, which we obviously use a different GFR measure for children than we do for adults. They've been able to do this with an equation across the age spectrum with a normalization factor, which they call Q, to correct for these parameters, but also have found that Q differs by different regions. So the Italian Q is a little different from the German Q or some other countries. And that really supports the idea that there may be a combination of environmental and genetic factors that account for these differences in the relationship to serum creatinine and actual GFR. This needs to be further explored. We don't fully understand that, particularly among Americans. And of course, there's social determinants of health, and their influence on serum creatinine is not well known. These are issues that need further research to fully account for. So what I want to make really clear is this uncertainty of estimated GFR, and it's probably something that we as nephrologists have not emphasized. This is an example of a relationship of GFR to serum creatinine in a 50-year-old, in which the orange represents the race-modified Black GFR, so to speak, and the blue represents if the 50-year-old were the equation were derived from a white individual. So this gives you the estimated GFR on in these dots and diamonds. So as you can see, there's not a whole lot of difference looking at there. What is remarkable is these bars that go across here. And this is the 95% confidence interval in that number. So this is the certainty that we have of that number. So for instance, this GFR of 130 could be anywhere from 90 to almost 180. And so there's more uncertainty in any given measure than this difference we're using or not using the race modifier. And that is a really key point that one must understand when you're thinking about estimating equations. So the real question is, what are the implications if we make changes? So if we remove the race modifier, there doesn't seem to be a change, that much of a difference with respect to the error involved in GFR. But when we think from a population level, removing this race coefficient is going to really decrease the GFR, because we will have less GFR amounts for Black people, therefore leading to a population number that is higher for CKD among Black individuals, and actually shifting Black individuals with CKD down. 30% of Black individuals would decrease to a lower stage, or be reclassified to a more severe stage of chronic kidney disease, which is not a small matter. So the impact of this change on clinical decision making is really the crux of the situation, right? And where it becomes an issue is on these thresholds, or these borders of GFR, which are important clinically. So here is in red. This is basically a graph that compares the estimated to the measured. So if the measured and estimated were the same, you'd be on the 0 line. So anything under the 0 line means the estimating equation is underestimating the GFR, and above it would be an overestimate of the GFR. And as you see, this is the red indicates the error, and the measure GFR without the coefficient, blue indicating the addition of the race coefficient for an African American individual. And so the clinical implications really lie in some of these threshold measures. So if a patient were, for instance, at this point, where if the race equation would consider this patient an adequate kidney donor, without the race coefficient, it would not consider that patient adequate as a donor candidate, which has clear implications. Over here, maybe the dose of medication may be adjusted downward to a low for the lower GFR, say for chemotherapy, which maybe have clear disadvantages to that patient if their actual GFR were higher, in which they would not get enough chemo. Or here, where along this range, you would use a certain agent that is protective to the kidney. You may take the patients off that agent because you feel that they're in a harmful GFR, but they may benefit from that GFR. Or at lower ranges where transplantation would not be considered because their GFR is too high. So these are some of the issues that would come up when we consider a change in GFR based on these estimating equations, removal or inclusion of the race modifier. So one of the issues with removal is that these GFR reports were based on actual measurements of GFR, and the race modifier was there to create accuracy among self-reported Black individuals. Removing this has the potential to devalue those that data that was put in over 3,000 Black individuals, and create a standard that is basically using data obtained mainly from white individuals. And when you're considering that it may shift a number of people to more severe CKD stage who are African American, this is an issue that we have to think about in our consideration of removal of the race modifier. So for instance, let's look at both sides of this coin. If the GFR is more accurate with race removal, then potentially we may have earlier detection of kidney disease among African American individuals, or referral to transplantation may be sooner. However, if it's less accurate and causes an underestimation of GFR, we may be giving a diagnosis of CKD to patients who don't have a CKD, or by definition, maybe subjecting them to higher insurance and worry underdosing medications, and maybe even having premature referral to dialysis or transplantation. The potential approaches to reporting is that we really need to emphasize that these are estimates and creatinine is not perfect. And this needs to be conveyed to patients in a way that patients can understand the limitations of these equations and the serum creatinine. We also need to consider developing equations that treat everybody the same in terms of the development of the equations, so that we can use them in diverse populations and have very inclusive patients that they're derived from. And we need to really focus. I think the bottom line is we need to focus on research that uses better biomarkers that do not need race modifiers for applicable, so that they can be applicable to all individuals, multiracial individuals, individuals who have not been included as in these equations as well, the development of these equations. So the National Kidney Foundation, American Society of Nephrology have formed this task force, which you may have heard of, the NKF-ASN task force on reassessing the inclusion of race in diagnosis of kidney disease. I've been fortunate to be a member of this task force, and this task force includes a number of people with with wide expertise in pharmacology, in lab medicine, social determinants of health, health services research, NIH experience, as well as patients and others. The charge of this NKF was to examine the inclusion of the race or the race modifier in equations, recognize the implications if we decide to change that reporting, incorporate the concerns of patients and the public, which we have done, and especially marginalized individuals, ensure that eGFR provide an unbiased assessment of kidney function to the best of our ability at this time, and keep laboratories, clinicians, health professionals apprised of the long-term implications. So in our deliberations, we've looked at a lot of data. We've heard from 97 experts from 7 countries and a broad range of topics, from social issues to clinical to research. An interim report has been published by the American Society of Nephrology, by NKF, in the JASN and AJKD journals. And it shows, this interim report shows how we approach the problem and the issue, and the attributes that would be important in making our final recommendations. And this summer, we will be coming out with our formal recommendation, our final recommendations that will hopefully be successfully implemented. Where I think it is important to have as much accuracy in our data that applies to all individuals of all races and ethnicities. This is one of us. This issue is one of a small issue, a number of issues related to social determinants of health, from economic instability to social issues that lead to health disparities. And I think we should not get distracted in that fixing this eGFR issue is going to fix all our problems related to health disparities. It is just one small part of the bigger issue. So I think the take-home message here is that estimated GFR equations are imperfect. They're imperfect. They are derived from imperfect markers and therefore have a lot of uncertainty. That race is not a biological attribute. It is a social construct and is an imprecise measure of ancestry. There are inclusion or exclusion of race modifier does have clinical implications that need to be considered, and that really truly benefit from a better biomarker that is accurate and does not need or rely on measures or attributes, social attributes at all. So I thank you for allowing me to present. I would like to acknowledge the NKF-ASN task force, the community for giving us their feedback, from health professionals to patients, to medical students and other clinicians. As those quotes say, I think we need to be honest with ourselves in terms of the data and try to deliver as much equitable care as possible. And clearly, we need to have significant effort in addressing health disparities in CKD. And one of the ways we could do that is by improving and advancing our ability for all people, all Americans and all people worldwide, on the assessment of kidney function. Thank you.
Thank you, Crystal. We appreciate your insights. We realize that this is a very difficult and important topic. We appreciate what you and the task force are doing. And I also remember the pre-COVID days when you and I, along with others, spent time talking about issues for ASN and AAKP up on Capitol Hill. We look forward to getting back to those good old days. Now, we're going to switch gears and we're going to talk about kidney transplantation, perspective, and policies to reduce organ discard. The first speaker on this topic is going to be Dr. John Snyder. Dr. Snyder is the director of the Scientific Registry for Transplant Recipients. Srtr, as it is known as, is the sister organization to OPOs, the Organ Procurement Organizations. And the charge of his organization is to provide and track data and information relative to kidney transplantation, as well as other solid organ transplants. But today the focus is going to be on kidney transplantation. I turn it over to Dr. Snyder.
Hello, my name is John Snyder. I'm the Director of Transplant Epidemiology at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota, and I have the privilege of serving as the Director of the Scientific Registry of Transplant Recipients, which I'm here to tell you some information about. I first want to begin by thanking the AAKP for the generous invitation to be with you today. I have gotten to know Mr. Knight over the years and consider him a friend, and really am thankful for the opportunity to talk with you all about the work of the Scientific Registry of Transplant Recipients and the fundamental direction we're taking to engage systematically the patient voice. And so my thanks to the AAKP for the opportunity to be with you today. Just a brief background, as I've mentioned, I serve as the Director of Transplant Epidemiology at Hennepin Healthcare Research Institute. We serve as the contractor with the federal government to operate the Scientific Registry of Transplant Recipients. And so I just note here that these views are expressed do not necessarily reflect those of the U.S. Department of Health and Human Services. I also have the privilege of serving on a few boards of directors in the field of organ transplantation. And so I just want to acknowledge the good work that's being done by Donate Life America and the Alliance for Organ Donation and Transplantation. I'm proud to serve on those boards. I also have the opportunity to serve on the clinical policy board of the Organ Procurement Organization that serves Minnesota, North Dakota, and South Dakota, and that is LifeSource. By way of background, I'd just like to point out where the Srtr sits in the operation of the nation's transplant system. The U.S. Department of Health and Human Services has the division, the Health Resources and Services Administration, which has a division of transplantation that operates two major contracts in the field of solid organ transplantation for the United States. On the left, we have the Organ Procurement and Transplantation Network, which is operated by the United Network for Organ Sharing in Richmond, Virginia. And a sister contract to that is the Srtr, the Scientific Registry of Transplant Recipients, which is operated by my team at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota. And the distinction I like to make between these two contracts, the OPTN UNOS system is, I would say, operates the nuts and bolts for the people in need of kidney transplants when they get put on a wait list. The OPTN manages that process, make sure the donors are being matched correctly and organs are getting to where they need to be and transplanted into those recipients. The Srtr serves primarily a research function as well as a public reporting function. So we are charged with monitoring the status of solid organ transplantation in the United States, and also consulting the policymaking bodies so that when they are considering changes to, for example, kidney allocation systems, our team may run a number of analyses for those committees to consider the data and hopefully make a correct decision in terms of how they're, or at least an informed decision in terms of how they're going to alter the policies to benefit patient outcomes. So the Srtr was established by the National Organ Transplant Act back in October of 1984. And this just gives you the public health law reference here. The Secretary shall, by grant or contract, develop and maintain a scientific registry of the recipients of organ transplants. And that registry shall include information respecting patients and transplant procedures as the Secretary deems necessary to an ongoing evaluation of the scientific and clinical status of organ transplantation. A lot of words, but essentially a scientific registry exists to help improve and monitor the nation's transplant system. So one of the main functions we serve is a public reporting function. We manage the website srtr.org, and you can see the reference there. And there's various performance metrics along with some other tools there that hopefully will provide useful information to patients in need of transplant. On the left here, I have an image of the United States. This is simply an image of some of the reports we have available at the portal into those reports for the 57 organ procurement organizations in the country. Those are the companies charged with working with deceased individuals to hopefully make their organs available for transplantation around the country. So those are designated by those colored regions on that map. So you can find reports about their performance and of those organ procurement organizations there. On the right, I have an image of one of the main pages of one of the transplant programs. In this case, I just picked out Ohio State University's transplant program, their kidney transplant program. And you can see just a highlight here of where that program is located, along with a couple key metrics that I can tell you a bit more about. One of the things we've worked on over the years is you will find if you peruse our reports that there are a number of very complex statistics in these reports. Assessing transplant program outcomes is a tricky business, right? So we have complex statistical models that we use to analyze outcomes and try to compare apples to apples across the different transplant programs. And so one of the things we're very proud of is we have, over the past 10 years, been really making a concerted effort to make the information more useful and understandable to patients. One of the ways we've done that is we've created these 5-tier systems that simply try to summarize a couple complex metrics into sort of, I think we're all familiar with looking at sort of 1 to 5 rating scales. And so in this example here, again, from Ohio State's program, we look at 3 main components of transplant program performance and rate them into these 5-tier systems so that patients can quickly get a good sense of how things are going at that program in the recent years. We look at survival on the wait list. So how well is are these programs patients staying alive while they're on the wait list in order to get organ offers? In the second one in the middle, how quickly is this program generally transplanting their patients? We know that all patients are unique and they have unique circumstances. And so we try to make adjustments in these models for the types of patients on their list and how acute they are. And so that is an overall assessment of all the patients on their list. Is this program transplanting them quickly or slowly? You can see this program here gets their patients transplanted quickly with a 5-bar rating in that as well. And then we look at outcomes. The summary here is first-year kidney survival after your transplant. So are you alive with a functioning transplant 1 year after the transplant? We know from talking with patients that 1 year is absolutely nice, but patients would also like to know longer-term outcomes. Now, within the reports, if you click through into more detailed data, we do have a 3-year outcome available, and we are currently working on a 5-year outcome as well. So hopefully stay tuned and you will see that 5-year outcome presented in the future. You'll find we've tried to produce some simple, engaging graphics in these reports. Here's a simple summary of the inflow and outflow of the Ohio State University Kidney Program's waiting list. And so you can see starting with 516 people in July of 2019, and then we go through a year period, and now they have 530 on their list. You can see the reasons that patients are removed from their list as well. And these reports update every 6 months. And so you'll see every 6 months in January and July, these data will update and show you the most recent 12-month period that we have available. We have simple summaries of how quickly patients are being transplanted to this program. Here you can move the slider at the top from 30 days to 1 year, 2 years, 3 years, and the data will change to show you at this program what proportion of their waitlist is transplanted by that time. So here we're seeing that at this program, 22% of the patients on the list have been transplanted by 1 year after listing. And that compares with nationally at the right 16%. So slightly higher than the national experience here. And this is what that gives this program that 5-tier rating for getting patients transplanted faster. This is a bit more complex, but I wanted the patients to be aware that we do have data in the reports that look at this program's proclivity to accept organ offers. We do know that some transplant programs are more aggressive in the types of donors they will use, and that may be reflected in when they receive offers for programs. Are they more or less likely than their peers to accept those offers? We do that by presenting what we call an offer acceptance ratio. And something right around 1.0 would mean that they are accepting offers right at the rate that we would expect them to accept them. In other words, they're doing just like the peers would nationally. If a program has a higher than expected offer acceptance ratio, you would see a number higher than 1. Say a 2 would mean that they're twice as likely to accept organ offers than other programs for similar candidates and similar donors. Or something like 0.5 would mean that they're half as likely to accept those offers. And so you can find data here for all offers. You can find data for certain hard to place types of donors. Is this program aggressive in accepting those? Often we see that programs that are more aggressive with their acceptance practices can get their patients transplanted faster. So we hope that these are useful data for the patients. So how are we systematically trying to engage the patient voice? The SRTR has an oversight committee that we would call our SRTR review committee. And just this year, we worked with HRSA to establish 3 subcommittees, one being the Patient and Family Affairs Subcommittee, and then we have what we call a Human-Centered Design Subcommittee, and finally an Analytic Methods Subcommittee. So the top 2 there, I think, are of most relevance to the patients themselves. The Patient and Family Affairs Subcommittee is advising the SRTR on issues of most importance to the patients and families that the transplant system serves. We're trying to systematically hear their recommendations in their voice. The Human-Centered Design Subcommittee then takes those recommendations and helps the SRTR design effective websites, effective reports. If our data are too complex for patients to understand, we know that they would not be useful. And so we're trying our best to take steps toward systematically developing reports that the patients will tell us are really helpful and useful to them. So we're thrilled to have those 2 committees that work together. The Analytic Methods Subcommittee is made up mostly of PhD level statisticians that can make sure that we're getting the methods correct behind all of this as well. Here's just a listing of our current Patient and Family Affairs Subcommittee. I won't go through the names. I will point out that we're fortunate to have Richard Knight as our co-chair of this committee, obviously current president of the AAKP. And so we're really blessed to have Richard's insights helping us here. Here's an image just for some of the work that the Human-Centered Design Subcommittee is helping us with. The image here is from a tool that's being developed by Dr. Corey Schaffhausen, who is our SRTR Human-Centered Design engineer. And this tool is part of a larger project that would help patients better understand the offer process when they're receiving offers for their organ. We want to make sure patients are prepared and ready to receive those offers and understand the relevant issues related to those offers. Just want to make the group aware that the SRTR also this year is embarking on a new initiative that we affectionately call Task 5. And that simply is a reference to our contract with HRSA. HRSA has asked us to engage in a process to identify metrics to assess national transplantation system performance and support informed decision-making by critical audiences. Obviously, the patient voice is a critical audience in terms of data that the SRTR can provide. So we're thrilled to have this new task that will really be underway for the next 5-year period to systematically identify these metrics. We're going to do that in a number of ways that I'll show you on the next slide. So here we see the process for Task 5, just highlighting on the left. It's a 5-year project. We are in year 1 currently. We have formed a steering committee. We are going to host a consensus conference as part of phase 2 that would take place approximately a year from now in the summer of 2022, where we hope to bring together many stakeholders in the transplant system and the data provided by the Srtr. We will hear recommendations. We will then spend the next phase implementing those recommendations and then systematically evaluating that change. On the right, the wheel is meant to represent that this is going to be an ongoing process going forward. We're hoping to systematically, about every 3 years, roll through a process of hearing from the community, making changes, evaluating those changes, and then hearing from the community again. So we will be looking for ways to engage the patient voice throughout this process going forward. We will be conducting patient focus groups as we lead up to the consensus conference. We have Dr. Allison Hart on our team. She is the senior staff for patient and family affairs, and she will be convening a number of patient focus groups. We hope to get broad representation from lots of different patients, genders, racial, ethnic makeup, geographic diversity as well. I'll have some contact information at the end of the presentation if that interests you to participate in those. So where can you stay informed? There's a lot of information. I encourage you to peruse the Srtr's website. If you have questions, the best way to contact us is emailing us at srtr@srtr.org, which is you can find at the bottom of the screen here. We have a newsletter. You can find the sign up for that there, srtr.org/#newsletter, and you can sign up for that. We have a Twitter feed, we have a LinkedIn, and we have a YouTube channel. You can find numerous webinars on our YouTube channel for helping patients navigate our data and website. And so we hope all these resources are available and useful to you. Encourage you to contact us at any time if you have questions about the data. And again, I thank the AAKP for the invitation to be with you today, and I look forward to meeting a number of you in the future as we engage the patient voice more directly. Thank you.
Thank you, Dr. Snyder. We appreciate the insights. We know, particularly during the past year when COVID-19 had an impact on information and data, we know that that added another level of difficulty to your job, but we think that your organization did a great job in spite of those impediments. Now, we're going to take a look at this issue from the transplant professional perspective. We're going to hear from Dr. Lloyd Ratner, who is the director of the Renal and Pancreatic Transplantation Department of Surgery at Columbia University Medical Center. Dr. Ratner is also the immediate past president of the American Society of Transplant Surgeons. He is a good friend of AAKP, and during his time as president of ASTS, he made certain that he invited AAKP to participate in the many venues where AST and ASTS discuss different issues relative to transplantation for kidneys. And now we're going to hear from Dr. Ratner, who is a welcome guest and a good friend of the organization. Dr. Ratner?
Hi, my name's Lloyd Ratner, and I am a professor of surgery at Columbia University in the city of New York, and I am the director of the Renal and Pancreatic Transplantation program here. The AAKP has asked me to talk this today about strategies to decrease kidney discards, which I'm happy to do. Unfortunately, I don't have any relevant financial disclosures. I do have a fiduciary disclosure in that I am the immediate past president of the American Society of Transplant Surgeons. However, all the opinions expressed in this presentation are strictly my own and don't represent those of any other organization, including the American Society of Transplant Surgeons. I'm going to talk about a number of strategies to reduce the kidney discard rate. And these are to reduce risk aversion, to improve allocation efficiency, to improve provider and patient education, to have a more realistic assessment of donor quality, and to provide a safety net for patients with suboptimal outcomes. And then I'm also going to tell some suggestions for policy strategies, which I think would help in these regards. So it's important to understand that there is a complex transplant ecosystem consisting of referring physicians and dialysis providers, donor hospitals, organ procurement organizations, transplant centers, payers, the organ procurement and transplant network and the allocation scheme, and regulatory agencies. And these interact, as you're going to see, and have an impact on whether or not we utilize or discard kidneys for transplantation. Now, as you're probably aware, the number of kidneys that are being procured and are being discarded from deceased donors has increased over the last decade or the last 2 decades. And now we're at about 20% or greater of the kidneys that are procured from deceased donors are being discarded. It's important to understand how the allocation system works in order to understand why kidneys are discarded. Now, the allocation system uses a construct called the Kidney Donor Profile Index, which basically what this is, it tells us a percentile ranking of the quality of the kidney in terms of its expected graft survival, so the kidney survival over 1 and 2 year period. And it uses a multivariate analysis, and you can see the variables that go into this multivariate analysis. But what's important to know is that there's a percentile ranking that gives you the quality of the kidney. The higher the percentile ranking, the worse the quality of the kidney, the worse the expected outcomes. It turns out that a very large percentage of these kidneys that are discarded are the high KDPI these high KDPI kidneys. And you could read the caption there. It says, "I've got good news and bad news. We found a donor, but the guy was 104 years old." Well, obviously that's not going to be optimal. If we look at the discards by KDPI, which is the percentile ranking, the absolute numerical value given to kidneys is what's called the KDRI, but let's stick our discussion to the KDPI. So if we look at a KDPI of 85% or greater, about half of those kidneys that are procured from donors that fall into that KDPI range are discarded. Okay, 50% of those kidneys are discarded, which is a huge amount. If we're going to increase the number of organs available, the large increase is most likely to come from the organs at the margin or from the donors at the margin. Now, if you look at the graph on the left, and there's a table within that graph, you can see, though, although 50% of high KDPI kidneys are discarded, 50% of the discarded kidneys are from donors that have KDPIs less than 85% or greater. So what would seem like good kidneys are being discarded as well. This is a picture. You can see a gentleman, that's Sumit Mohan. He's one of my colleagues at Columbia University. And we published this finding that the discard of kidneys varies by day of the week. And those with the discards being greater on the weekend, and the kidneys that are discarded on the weekend tend to be of better quality than those kidneys that are discarded on weekdays. Okay? It's like there are more bad kidneys on the weekends. The discard rate goes up, meaning we have to discard kidneys that are of better quality. Now, that implies that it's not just the quality of the kidney that is factoring into why these kidneys are being discarded, but rather organizational and operational factors at the level of the transplant center that impact whether or not kidneys will be discarded or not. Dr. Mohan and our group went on to publish another paper which also shows that there is huge geographic variability in the chance of getting a kidney and utilization of organs. And this graph shows broken down into the 11 UNOS regions. But you could see the vertical bars also show the variability between centers within a given region. And you can see there's very wide variability from one center to the next, whether someone will get transplanted, and correspondingly, whether or not they'll utilize organs and whether or not those organs will be discarded. So again, there's a systemic problem here. So let's start with the first issue, and that's that of risk aversion. Well, currently, the regulatory environment that looks at transplant center performance looks at outcome measures, and they focus on 1-year patient and graft survival. Important in that is that there's an imperfect risk adjustment. So we get compared to the national average. They try to risk adjust based on the quality of the donor and how sick the recipient is. But the risk adjustment is a little bit better than a coin toss. The problem is further compounded by the fact that it's a punitive system. So if you get flagged as being performing less than expected, you get punished or can be punished. And there's no incentives to utilize suboptimal kidneys. There's an imperfect risk adjustment, so it doesn't, all the factors that go into why a kidney is not optimal to use doesn't go into the outcomes measures, and so you could only get hurt if you go out on a limb and use a suboptimal kidney from the standpoint of the transplant center. Now, there are also financial risk aversions. Recipients of these suboptimal kidneys are generally harder to take care of and tend to be more expensive. They have longer length of stay in the hospital. Many of them, and I'll show you some data about this, need for postoperative dialysis, which is more expensive. And yet there's no differential payment for whether or not you're going to use a suboptimal kidney versus an optimal kidney. And so centers with narrow margins are disincentivized to utilize these suboptimal kidneys, which then leads to their discard. There are a number of things which will impact a center's risk tolerance and or aversion. Things like the risk of primary non-function or delayed graft function. Primary non-function is when the kidney never works. Delayed graft function is when the patients require dialysis after the transplant until the kidney recovers. Whether or not they ever get to optimal function or whether they just kind of sputter along suboptimally and only give, sort of partial function to the recipient. Whether or not they're expecting to have a shorter graft survival. If they've been injured in some way and are likely to bleed, which make it more difficult to manage the patient. If they're at risk for ureteral or vascular complications, or if they're at risk for transmitting diseases like HIV, hepatitis C, parasitic diseases, cancers, et cetera, et cetera. So all of these things factor into why centers may have risk-averse behavior with some kidneys. This is a very famous graph. This was published by Jesse Schold from the Cleveland Clinic, who basically looked at centers and looked at their outcomes. And the top line, line number 1, shows the patient survival in those centers that consistently perform better than expected. The second line is the patient survival in those centers that consistently performed as expected. And the third line is the patient survival in those centers that consistently performed less than expected in terms of their outcomes. Okay, those centers that are likely to be flagged for suboptimal performance. But when you compare that to the fourth line, which is those patients who are transplant candidates on the waiting list who don't get transplanted and remain on dialysis, you can see the patient survival is hugely better, even in the worst performing transplant centers. Well, why is that so important? Well, because again, those centers fall into a punitive system. And Schold then went on to further show that anytime a center gets flagged for having suboptimal or low performance under expected, then in general, their volume of transplants decreases by about 30%. So making it more likely that they'll discard organs and making it more likely that they won't take on difficult patients. Let's talk a little bit about allocation efficiency. Well, the allocation algorithm is complex, but to a large extent, it's driven by waiting time. People with long waiting times are unlikely to accept suboptimal kidneys. So, for instance, I call up Mrs. Jones and I say, Mrs. Jones, we have a kidney for you. We have a wonderful kidney for you. You've been waiting 8 years. And she says, oh, Dr. Ratner, I'm so excited. But is this a good kidney? And I said, well, yes, this is a very good kidney, but 90% of kidneys are better than it because it's a 90% KDPI. Who would wait for 8 years and then accept that kidney when maybe 2 weeks or a month later, they'll get a much better donor kidney? Okay, so then we go to the next person on the list, same discussion, on and on down the list, okay? And as that goes on, as we keep offering the kidney to more and more patients, the amount of time it takes, the clock is ticking. So the longer the kidney is outside of a living human being, the greater the chance it won't function appropriately. So these long allocation times make suboptimal kidneys even more suboptimal. Then you get to the point where you have transportation logistics, and these are problematic. And so if you can't allocate it to someone locally and you need to make a broader net to send to and try and get it allocated nationally, well, the kidneys fly on commercial airlines. And, so if there are no flights available because now you've spent the last 6 hours trying to allocate the kidney and now it's 8 o'clock at night and there are no flights until the next morning, you've just added an additional 12 or 14 or 15 hours onto the kidney. These long allocation times are often compounded by lack of flights and long logistical delays. Now, my point here is that, these wind up because we're talking about trying to have equity, and, those patients who have waited the longest should get the first shot at the kidneys. Well, my point is that if these kidneys aren't going to be utilized, there's no utility. Without utility, then equity is moot. So we should have a much more efficient allocation system, which could get to these kidneys to people that would actually use them. Well, let's talk about these hard-to-place kidneys. Well, this is a paper from a paper that my group has recently submitted that looked at hard-to-place kidneys. Now, UNOS defines hard-to-place kidneys as those where you go down to the 100th person on the list or greater to get this kidney accepted. Okay, so we looked at those kidneys that were transplanted into patients 1 through 7 on the list, 8 through 100, and then we looked at the hard-to-place 101 to 1,000, and then we looked at these super hard-to-place where we went down greater than 1,000 patients on the waiting list. And if you look at the highlighted yellow areas, the first area that you see is the cold ischemic time. So you could see that the hard-to-place kidneys, 100 or greater, have about 10 more hours of ischemic time outside of a living human being, than those sort of optimally placed kidneys. And if you go to the super hard-to-place kidneys, they're about 15 hours for the other ones and 18 hours for the super hard-to-place kidneys. So we're sort of hurting these suboptimal kidneys even more. And that's reflected in the outcome. So if you look at the bottom yellow boxes, the PNF stands for primary non-function. Those are kidneys that never work. It's about a 3-fold difference between these hard-to-place kidneys that are more likely to be discarded, and the delayed graft function, in other words, needing dialysis following transplant, is about twice as much. So again, making it more difficult to place these kidneys with suboptimal outcomes, although these outcomes are still very, very good. But in our current punitive system, there's risk aversion because of that. Overall, these generally tend to do well, and you could see that although there is a statistically significant difference in terms of the outcomes for the hard-to-place kidneys, which are the lower 2 lines, versus the upper 2 lines, which are the easier to place kidneys. The outcomes are still quite acceptable and way, 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 way better than on dialysis. So let's talk about provider and patient education. Well, there's that of organ acceptance. Well, I think, like I tried to explain to you with the issue of the KDPI, the consent and allocation process are pejorative to the kidneys. We have to disclose all these facts about the donors, whether they were at risk for contracting other illnesses and things like that. Kidneys for transplantation are sort of like used cars. You can never get a brand new one right from the factory. Some will have more mileage than others. Some have been maintained better than others, but you're never going to get a perfect one. I think another misunderstanding is that the degree of HLA matching is really of limited significance, and the risk of disease transmission is really extraordinarily low, even in those people who have social behaviors which would make them seem like they're at risk for developing diseases like HIV, hepatitis C, etc. What we really need, and we have some, are prognostic tools that tell us, number one, what's the chance of dying on the waiting list? What's the likelihood of getting a better kidney offer? How long will it take to get a better kidney than the offer currently at hand? And how can these tools realistically be incorporated into the real world situation? Because when I get a kidney offer at 3 in the morning and I may be operating, there's no way we could go and look into these calculators, and it's unlikely that the patients will utilize them either, and we have very limited time to make decisions about this. So we need more realistic utilization of tools like this. So let's talk about a safety net for patients with suboptimal outcomes. Well, if a kidney fails early on, the patient will get their waiting time back. But there are no accommodations for kidneys that never function well but kind of continue to sputter along. So, if we look at glomerular filtration rate, maybe someone will get a kidney where the glomerular filtration rate is only about 22 or 23%. It may keep them off dialysis, but that's not much better than an end-stage kidney. So there's no real incentive for patients to accept a kidney like that. Patients should be prioritized if they accept a suboptimal kidney that either fails early on or functions poorly. There is a precedent in terms of the safety net for liver transplant recipients who have kidney disease who may also be candidates for a kidney, but now if they just get the liver transplant, they are prioritized to get a kidney later on if it turns out that they really need a kidney transplant. I think we also need a more realistic assessment of donor quality. I talked a little bit about the risk adjustment. Well, things like high KDPI, donors at extremes of age, elevated creatinine versus acute kidney injury, or long ischemic times, those go into the risk adjustment, but things that don't include comorbid conditions, pathologic features when you look at the kidney on a biopsy. If you put them on a perfusion pump, we could use those pump parameters, the flow rates and resistance within the pump as prognostic factors, the risk of disease transmission, and whether or not the kidneys, what I call, are anatomically incorrect. Do they have any procurement injuries or injuries from the cause of death, like a motor vehicle accident, tumors, whether they have anomalies, congenital anomalies, and whether they have multiple vessels. None of that goes into the risk adjustment or the assessment of donor quality, but they do go into our assessment of whether we use them or not. Well, here's my favorite philosopher, Yogi Berra. He said, if people don't want to come out to the ballpark, how are you going to stop them? That was in the time when television first came out and people were watching TV rather than going to the ballpark. So the Ratner corollary is, if people don't want to transplant kidneys, how are you going to stop them? Well, I think we need to change performance metrics to assess the entire continuum of care with an intent to treat analysis that looks at evaluation, listing, pre-transplant, transplant, and post-transplant, and that'll encourage people to utilize more kidneys. What I call dealing from the bottom of the deck, and that's that if we give these suboptimal kidneys to the patients with short waiting times rather than the patients with long waiting times, this will mitigate the suboptimal outcomes of these high KDPI kidneys. It's difficult to do this with our current allocation system. And with these kidneys, recipient selection is critical. So the idea is to give these suboptimal kidneys to the patients with the shortest waiting times who are unlikely to survive to get to the point where they'll be getting better offers. And then finally, what I call the wild card solution. And this is to encourage listing of patients. We would say that a percentage of those patients who get listed can receive the wildcard designation, maybe 5%. So a wildcard designation will exclude patients from the overall performance metrics. But you would have to designate this wildcard prospectively before transplant. So what that would do is would encourage transplant centers to transplant patients with risks not included in the risk adjustment, but also to be able to utilize kidneys that are not accounted for in the risk adjustment. You just declare it prospectively and say, okay, I'm going to transplant this kidney into this patient, and they're going to be a wild card patient, be removed from the performance metric. It would also encourage cohorting of patients with difficult problems, and it would encourage innovation and experimentation. So I think that's a good way to solve a bunch of problems. So in summary, there are a number of interrelated factors that lead to kidney discards. Current policy does not discourage the discard of kidneys. Risk aversion and allocation inefficiency play important roles in organ discard. Reduction of kidney discards will likely result in suboptimal outcomes, but those suboptimal outcomes will be better than the alternative of not being transplanted. And there are a number of policy approaches to addressing this problem. So I'd like to thank the AAKP for allowing me the opportunity to address you today, and I wish you all good luck.
Thank you, Dr. Ratner, for that great presentation. We always appreciate hearing from you, and as usual, you provided great insight to the patient community. Thank you so much. We're going to take a look at examining the PharmD and the kidney-patient relationship in current research and expanding the care team. And to take us through this topic, we're going to hear from Dr. Wendy St. Peter, who is a professor at the College of Pharmacy at the University of Minnesota. Dr. St. Peter, I turn it over to you.
Hello, I am so honored to be asked by AAKP to talk to you today about advancing your kidney health. I am Wendy St. Peter. I'm first and foremost a pharmacist. I'm also a professor at the University of Minnesota College of Pharmacy. I have worked with chronic kidney disease patients, hemodialysis, as well as chronic kidney disease patients for many years. And I also do research where I evaluate large databases and look through those databases to see if medications are safe and effective. I'd like to talk about the importance of taking charge of your medications for your health and the importance of developing a relationship with your pharmacist to help you self-manage your medications. And at the end, I'm going to be talking to you about a national initiative that I'm leading on advancing kidney health through optimal medication management. Now, if you're a chronic kidney disease patient, or you're on dialysis, or have a transplant, you're a veteran of getting new medications. You see this danger sign on the slide. It's because every time you get a new medication, it sets up an at-risk situation. I want you to know that you can't assume that your doctor knows everything about your medication. And medication danger increases when you have multiple doctors who may not be talking to each other, many medications, which can increase the risk of drug interactions or food-drug interactions. Rush clinic visits with your physicians where they don't have enough time to really talk to you about your medications and how they work. And then importantly, a big danger zone is a poor communication that sometimes happens when you as a patient go from, let's say, home to the hospital or hospital back to the dialysis unit, where sometimes that communication, and especially about your medications, gets jumbled and the right information is not given. It's really important to know that you are your own best advocate. You are the key member of your healthcare team. As somebody that has chronic kidney disease, you see a number of different healthcare professionals that are also part of your team. Like your nephrologist, you may have a primary care doctor. If you have a transplant, you have a transplant team. If you're on dialysis or have late-stage chronic kidney disease, you may also have a dietitian and a social worker. But I also want to let you know that a really important member of your team is your pharmacist. And I'm going to talk about that in a moment. But first, I want to focus in on advocacy for yourself. There is an engagement score. It's known as the Patient Activation Measure, which measures patients' engagement in their healthcare. And as you can see on this slide, there's different levels. So depending on how patients answer the questions in the survey, they are put into different levels. And for instance, level 1 shows a patient that's oftentimes disengaged, overwhelmed with their healthcare issues. Oftentimes these individuals are somewhat passive. They lack confidence in the knowledge about their healthcare conditions or their medications. Knowledge is oftentimes low, and adherence to medications is often poor, or other therapies. And oftentimes these patients think, my doctor's in charge of my health. That's not the case. You're in charge of your health. And in fact, as patients increase their engagement and activation in their healthcare, you can see things like going up to level 4, where patients are maintaining behaviors, very healthy behaviors. They may struggle in times of stress or change, for instance, like when you go from being a chronic kidney disease patient to reaching end-stage kidney disease, where you need extra help, but maintaining a healthy lifestyle is their key focus, and they are their own healthcare advocate. And this is where we want most patients to be, in level 3 and level 4 activation. The Patient Activation Measure, or PAM as it's known for short, is a survey that is administered to patients that assesses them on their own self-care management skills. So one question that is on this PAM score is, I know what each of my prescribed medications do. And so patients will disagree strongly to all the way to agree strongly on that measure. Another question is, I'm confident that I can follow through on medical treatments, that would include medications, that I may need to do at home. So these 13 questions really gauges the activation or engagement of patients in healthcare. And this is really important because the Centers for Medicare and Medicaid Services are using this PAM measure in some of their new value-based models of care that they're rolling out in nephrology practices that have volunteered to participate in these new models. And patients that are in these practices will be required to do these surveys twice a year. So why is this important? Well, a single point change in that PAM score has been associated with a 2% increase in medication adherence, and importantly, a 2% decrease in hospitalization. So the higher your patient engagement in your own health care, it makes a difference, an appreciable difference in medication adherence and hospitalizations. So what is the first step for you becoming an advocate and an activated patient in terms of your medication management? When you get a new medication, there should be a series of questions that you ask your doctor and your pharmacist. 1, do I really need this? I'm on a number of medications already. Is this going to help me? And how is this going to help me? What is this for? Will this take the place of anything else I am using? think you might be surprised that when you have multiple doctors, one doctor may not be aware of another medication that you are on that may be very similar to the one that they're prescribing for you. Also, on the top of the right-hand screen, when will the medication start working? Is it going to be immediately or down the road? Am I going to feel any differently? If I don't feel any differently, how is it working for me? Is there anything I should watch out for in terms of side effects or how I'm feeling? There's a whole list of questions here. All of them are important, and they're available in a downloadable printable brochure at the FDA website and the web address that I have at the bottom of the slide. So I would suggest that you take this brochure with you and ask those questions every time you get a new medication. But of course, there is oftentimes lots of information that could be conveyed and should be conveyed, but oftentimes doctors don't have time to do that. So step 2 is making a clinical pharmacist part of your care team. Now, there are different types of pharmacists, but we have clinical pharmacists that are oftentimes with primary care practice. They may be in a specialty practice like a diabetes center. They may work in an oncology clinic, blood thinner clinic. We have lots of clinical pharmacists out there in practice today that all they do is work with patients that have complex diseases and complex medication management. And they can help you in terms of knowing about your medications and helping you assist in your own self-care management with those medications. So clinical pharmacists can help you learn about what medications can help slow your kidney disease or keep your kidney transplant healthy. We have a number of new medications on the market today that have been shown to reduce progression of kidney disease. And it's important that we get those medications into the hands of those of you that need it. And so a clinical pharmacist can help you access those medications. The pharmacist also makes sure that each medication is safe, effective, and convenient for you to use, which will help reduce side effects and the potential for drug interactions. And importantly, they can help you focus on the medication issues that are important to you so that you can live life your way. We feel so strongly that clinical pharmacists should be a part of your care team that we've developed an initiative to advance kidney health through optimal medication management. And our vision is that every person with kidney disease receives optimal medication management through team-based care, including a pharmacist, to ensure their medications are safe, effective, and convenient for them to use. And so our mission is to engage pharmacists and key stakeholders like you as patients and other key stakeholders to develop partnerships for optimal medication management in kidney disease to improve your and other patients' health outcomes and to reduce healthcare costs. We have 3 main strategic initiatives. One is to develop pharmacy practice education standards and pharmacy training focused in kidney diseases. Importantly, engaging key stakeholders like you to drive optimal medication management practices into your health care. And how are we going to do that? We're in the process of developing a learning and action collaborative to help kidney practices and the nephrologists and other healthcare practitioners in those practices include pharmacists to assist patients with medication management. Who have we engaged? Well, we've just not engaged pharmacists. We've engaged patient advocacy organizations like the AAKP. That's why I'm giving the presentation today. And other patient advocacy organizations like Home Hemodialyzers United and Medical Education Institute. Some of you may have answered a recent survey on how you view your pharmacist and how your pharmacist has helped you in your medication management. We also are engaging pharmacy organizations like the American College of Clinical Pharmacy and other pharmacy coalitions, colleges of pharmacy, The National Kidney Foundation is helping us with policy-related issues. And we've got the Renal Physicians Association, which is the advocacy body for physicians and nephrologists in this country, on our work group. We are also engaging with the Centers for Medicare and Medicaid Services so that as they develop new policy and new guidance, especially within these new models of care, that these guidance and policies are beneficial and can promote having pharmacists work with patients in this way. So our key message today, my key message to you is be an active member of your healthcare team. As part of that, advocate for a clinical pharmacist to be a part of your team. And not just a part of your team, but advocate that every person with kidney disease should have a clinical pharmacist to help make sure their medications are safe, effective, and convenient for them to use. We are urging you to join our initiative. We need your help. So if you are interested in joining our initiative or have questions that I can answer, I would like you to contact me. I'm Wendy St. Peter. You can see my email address on this slide. We want you to join our team because we want to increase optimal medication management in patients like you. Thank you for your attention.
Thank you, Dr. St. Peter, for that fine presentation. We really appreciate your insights that you provided to us during that session. And now we're going to move to our next session, where we're going to talk on the topic of community policy, a united effort to create and enhance the National Living Donor Assistance Center to increase kidney transplantation. This is an exciting program, and to speak on the topic is a longtime friend of mine, Miss Kim Guilford, who I've known since she was the executive director of ASTS. Now she is serving as the program manager for the National Living Donor Assistance Center, the American Society of Transplant Surgeons. Kim, the floor is yours.
Hello, my name is Kim Gifford, and it's an honor to be here with you today to speak about the National Living Donor Assistance Center and how the community has contributed to the development and enhancement of the program. When we speak about the National Living Donor Assistance Center, we use the acronym MILDAC. Today, MILDAC exists as a national program that reimburses non-medical expenses associated with living organ donation. While medical costs are generally covered by the recipient's insurance, we know that travel expenses, lost wages, and dependent care are often not covered, and these expenses can represent significant barriers for many people interested in living organ donation. The mission of MILDAC is to reduce financial disincentives to living organ donation. The program is funded through a collaborative agreement with HRSA, the Health Resources and Services Administration. Our team has been administering the grant since its inception in 2007. When we initially launched, we focused solely on the reimbursement of travel expenses. Over the past year, based on some exciting regulatory changes, we were able to add lost wage and dependent care reimbursement to the portfolio of allowable expenses through the MILDAC program. Here you can see the logos of the organizations that work collaboratively on the MILDAC program. We work closely with our colleagues across the country and very collaboratively with HRSA to fulfill the goals of the program. MILDAC also uses an advisory group as a mechanism to have ongoing feedback from the community. The advisory group has representatives from all the organizations that you see listed here, and we meet several times a year to report outcomes, to seek community input, and to maintain a focus on continued improvement of the program. So I wanted to start with this brief overview of MILDAC so you would be familiar with the program, but now I'm going to take a step back and talk about how the community helped develop this important program. There are two key pieces of legislation that set the groundwork for MILDAC. The first is the National Organ Transplant Act, which is known as NOTA, that was passed into law in 1994. 20 years later, the Organ Donation and Recovery Improvement Act, known as ODRIA, was the second piece of critical legislation. Both of these were bipartisan bills supported by the broad community, including advocates from AAKP. NOTA was important because it established the national systems that guide transplantation today. It established the Organ Procurement and Transplantation Network, the Scientific Registry of Transplant Recipients, and the Division of Transplantation as the administrative arm to oversee transplant activities. NOTA also prohibited the buying and selling of organs and provides for monetary fines and/or imprisonment for these cases. But even in the bill, from the very beginning, it clarified that reimbursement of travel expenses and lost wages is allowable and did not violate the law. ODRIA was passed in 2004, and it included a variety of initiatives designed to increase organ donation and to help more people on the waiting list get a transplant. Important to our discussions today was the inclusion of language in ODRIA that allowed the use of federal dollars to reimburse living donors' travel expenses and other non-medical expenses as authorized by the HHS Secretary. Federal reimbursement was deemed allowable except in the 3 cases that you see listed here: if an insurance company, a state program, or the recipient of the organ can cover the expense. This last bullet is important because it brings an element of means testing to the program that is necessary in order to comply with the law. So despite the depiction in Schoolhouse Rock that becoming a law is the end of the journey, I would argue that in many cases it's just the beginning, because once the law is passed, there has to be regulation developed to support the law. This was definitely the case for NILDAC, and our regulatory process took place through HRSA and the federal rulemaking process. For those of you who are less familiar with the federal rulemaking process, I'd like to share a brief, albeit a complete outsider's view of this process. The president may direct an agency to take action, as happened with the Advancing American Kidney Health Initiative. We saw this in 2019. There also are times when Congress can direct an agency to take action, as happened when ODRIA was passed in 2004. An agency can also initiate the federal rulemaking process as long as their work falls within their scope of authority. And all agencies that develop regulation must follow an open process that includes the opportunity for public comment. So public comment is an important part of the federal rulemaking process, and anyone can submit comments on a proposed rule. It's important to know that this is not a numbers game, and the outcome is not decided by the number of people who comment for or against a proposal. However, it is an important opportunity to be able to submit data, to submit expert opinions, and other facts that can help the agency finalize regulation. And while it can seem like a daunting process, your voice can and often does impact a final rule. So how do you learn about this rulemaking process and the opportunity to submit comment? Well, the Federal Register is the official publication of the government, and it's where they publish rules, proposed rules, notices, executive orders, and other presidential documents. It's published every weekday except for federal holidays, and I've listed the website here if you'd like to learn more about the Federal Register. It is a vast repository of information. It is not easy reading, but they have some tools that help you set up alerts if there's a particular topic that's of interest to you and that you would like to follow in the Federal Register. So at this point, if you're saying to yourself, what does the Federal Register have to do with NILDAC? We're going to take a look at the next slide to see how the Federal Register and NILDAC have intersected over the years. Since 2005, there have been 12 publications in the Federal Register related to the NILDAC program. It started in 2005 after ODRIA was passed into law when HRSA sought feedback on the program that they used to develop their request for proposals. Subsequent to that, a proposal went out. Our team was awarded the initial collaborative grant. We convened the advisory group. And in April of 2007, there was a request for public comment on the eligibility and qualifying expenses for NILDAC based on the recommendations that came from our team and the advisory group. So in the early days, this proposed rule solicited about 29 comments. And interestingly, the government had thought about finalizing one income threshold, but based on the community comments, they ended up finalizing an income threshold that was higher. Again, more proof that your voice does have an impact in this process. And over the next 2 years, we had minor adjustments to the eligibility for NILDAC. And as you can see, in 2008 and 2009, there weren't very significant changes, and the public comment was pretty minimal. As we moved into 2010, HRSA sought feedback on expanding qualifying expenses as was allowed in the initial law. Then you see we have this gap, and things were pretty quiet on the Federal Register front in regards to NILDAC until the executive order on advancing American kidney health was announced in 2019. As I'm sure many of you know, this set in motion positive initiatives in kidney care and in transplantation, including renewed talk of expanding NILDAC. In late 2019, HRSA asked for feedback from the public on adding lost wages and dependent care to the portfolio of allowable expenses. And then in March, they sought public comment on changes to the program eligibility. The proposed rule on lost wages and dependent care received over 267 comments. The request for public comment on changes to eligibility received 77 comments. And a final rule was then released in September of 2020. These two most recent Federal Register activities generated over 340 public comments that helped shape the final rule and the final notice, which led to some wonderful expansion in the NILDAC program. So thanks to the public comments and the receptiveness of HRSA, these changes were implemented to the program. Input from organizations such as AAKP and others resulted in the addition of lost wages and dependent care reimbursement added to the portfolio of the already existing travel reimbursement program. As I mentioned early on, the law is a component around means testing. It had been set at 300% of HHS poverty guidelines and was increased to 350%, which should capture about 67% of US households. The other addition that came out of this rulemaking process was that anonymous, non-directed donors can apply without an identified recipient. This is a much easier pathway for non-directed donors to have access to NILDAC funds. We are very grateful for the community involvement in these important changes. And if you or you know somebody who is considering living organ donation, I hope that you will check out the program and apply for NILDAC resources if you're eligible. In the big workings of federal government, I know that we are a small program. However, we're very proud of the work that we do to support living organ donors and their recipients. Here is a snapshot of Mildax Impact since the program's inception. We have had over 11,000 approved applicants. Over half of our applicants go on to complete surgery. So you can see over 6,000 surgeries have been facilitated through NILDAC funding. We have distributed over $21 million in reimbursement for travel, lost wages, independent care expenses incurred by these living donors. And most gratifying is that 75% of donors report that NILDAC funding helped their ability to donate. So That is over 4,500 incremental donors added to the system since 2007. That's 4,500 lives saved by donors that received what in the big picture is pretty modest funding through this federally supported program. That funding allowed them to pursue their desire to be a living organ donor. We know that this money saves the we know that this program ultimately saves the government money. We published a paper in Clinical Transplantation in 2018 that estimated government savings in dialysis costs from incremental transplants facilitated through NILDAC was over $256 million. I think that's a great return on investment compared to the total NILDAC costs. And if you're interested in learning more about the ROI on the NILDAC program, the paper is available via open access on Clinical Transplant's website, and I'll encourage you to check it out. So as I have said throughout this presentation, NILDAC support is made possible because of HRSA's strong commitment to living donors and their receptiveness to the community's input that helped develop and launch this program. If you want to learn more about the NILDAC program, I encourage you to follow us on social media, visit our website, and leverage free resources that we've made available. In closing, I hope that this presentation encourages you to take part in future rulemaking, whether it's on issues around NILDAC, transplant, kidney care, or whatever that you feel passionate about. And if we can be of any service to you, please feel free to contact our office and learn more about NILDAC. Thank you to the organizers of this meeting and to AAKP for this opportunity to join you today.
Thank you, Kim. That was a fine presentation. We appreciate your leadership in this area. This program provides great assistance to patients who are in need and is another way for them to have support in pursuing a kidney transplant. And I'd also like to thank the panel overall. All of our guest speakers have provided tremendous information for which we are very grateful. I wish everyone a good day.